ज्वाइन कर यूट्यूब पर।
Bhavin bhai, you can now come on the screen. We'll be starting. Bhavin bhai. Yes. First, let me introduce you. Somebody's audio is making a lot of noise. Let me mute it. Yes. So, good morning, all friends. Welcome back to Saturday morning meeting. And today we have very eminent ENT surgeon in the local parlance, but what he's basically is an otologist. So this is his main area of interest. And Dr. Bhavin Parikh completed his MS post-graduation training in ENT and head and neck surgery under MS University of Baroda. So he is one of us, an alum of Baroda Medical College. He was one of the 2 candidates selected throughout the India for super specialty training in otology and neuro-otology at Rajiv Gandhi University of Health Sciences, Bangalore, which includes surgical training in micro-ear surgery, facial nerve and lateral skull-based surgery under the leading otologists of India. And after completion of fellowship, he worked as a consultant at same fellowship center. And then Dr. Bhavin was selected for scholarship to attend one of the world's best otology and skull-based center at France for a period of 6 months. Interestingly, he is co-author of the book Surgical Techniques in Chronic Otitis Media and Otosclerosis, Text and Atlas, which has within a short duration of 8 years sold more than 3,000 copies and has become a textbook for learning ear surgery in entire Southeast Asia. Really matter of great proud for us because to get this kind of popularity for a book is difficult in medical literature. Dr. Bhavin has also co-authored a book on skull-based surgery, functional surgery of cerebellopontine angle by minimally invasive retrosigmoid approach. That was released in April 2013 at the European Academy meeting in Nice, France. Dr. Bhavin has published more than 20 papers in various journals. At present, he is consultant otologist and ENT surgeon at Bharti ENT Care Hospital, Nizampura, Baroda. So with this brief introduction, I request Dr. Bhavin Parikh to start his talk on peripheral vertigo. Bhavin bhai, you have about 40-45 minutes to talk, and then we'll have 10-15 minutes of discussion. So over to you, Bhavin bhai.
Thank you, sir. Thank you for the kind introduction. And thanks once again to Saturday Club for inviting me. I have been associated with Saturday Club since last 8 to 9 years. And it has always been pride to present in front of our alumni and Saturday Club. So with that, I will start my lecture. And I think anyone can stop me in between also if you want. And I will take the lecture from most basic perspective, like how to diagnose peripheral vertigo, how to differentiate it from central vertigo, and what are the common causes of peripheral vertigo. So as we know, vertigo, there are certain things which are very misleading for vertigo. First thing is vertigo is a symptom and it is not a disease. So many of our patients come with the diagnosis of that I have vertigo, but vertigo is, and generally dizziness is one of the top 5 common symptoms with which the patient presents to a primary physician. And in Western countries, usually it is among the top 3 symptoms with which patient present to a primary physician. So it is after headache, fever, and pain. This is one of the commonest symptoms, and so we need to understand better about this symptom, what it is, and what are the common disorders associated with this symptom. And the second thing is, this is one of the most mismanaged or undermanaged symptom. We have very standard protocols for fever. We have very standard protocols for headache or for any chronic pain syndrome, but vertigo still remains undermanaged or mismanaged. So with that, I start this lecture. Vertigo, as in a sense, is any false sense of motion, which is illusionary, means the actual, there is no movement, but the patient feels the movement. So that is called vertigo. And there are different types of dizziness. So vertigo is one of the form of dizziness. Vertigo is actually a illusion of movement, mostly rotatory movement, and it is part of the four spectrum. The second is disequilibrium or unsteadiness. That is unsteadiness in the lower body, inability to walk properly, but they don't have any spinning sensation in head or no other problems, and the symptoms settles down when they sit down. However, vertigo, the symptoms may be there even on sitting down or sleeping also. And the third part of dizziness is pre-syncope, which is completely a vascular cause, or what we say blackout episodes or feeling of faintness or loss of consciousness. And the fourth part is lightheadedness, where the patient cannot describe exactly what he is having, like swimming sensation, floating sensation, or feeling of dissociation. So if we see all the four, the first two, the vertigo and the disequilibrium, are usually caused by peripheral or central. Peripheral means the vestibular system or central nervous system. Pre-syncope, the usual cause are cardiologic causes, and lightheadedness is normally because of functional causes. So as we see, the prevalence rate is high. 5 to 10% of population has vertigo at a time, and it is common after 40 years of age and has a marked female preponderance. Just going through little bit of physiology, like balancing systems are mainly based on three inputs. That is, the main input is vestibular system, but if the vestibular system is disturbed, the supporting systems are optical eye and the proprioceptive systems. So all the three systems sends the sensory input, which is processed by central nervous system, mainly cerebellum and brainstem, and then with various reflexes between the vestibular system and eye, vestibular system and spinal cord, and different reflexes. This is how we maintain our balance. This is a short video, but about physiology of vertigo.
Sense of balance and vertigo. In addition to hearing, the ear also plays an important role in maintaining balance. The inner ear has a balance organ made of the vestibule and 3 semicircular canals. The semicircular canals are arranged at right angles to each other. The balance organ is filled with fluid, and on movement of the head, currents are produced in the fluid. The semicircular canals sense rotational motion of the head by detecting currents produced in this fluid with receptors called hair cells. It transmits this information through the balance nerve to the brain. Similarly, in the vestibule, sensitive hair cells overlaid by crystals called otoliths help detect linear movement of the head. If the brain is unable to match this information with the information received from the ears, eyes, and muscles and joints, one gets the feeling of the surroundings spinning.
So basically, if the vestibular system of both the side is normal and sends balanced input from both the side, the patient or a normal human being has a sense of balance. But when one of the vestibular system gets injured or damaged due to multiple causes, as we see, then there is asymmetry of vestibular input, and that is what causes vertigo. So this is again another animation to show what happens when there is sudden loss of vestibular input on one side. So if we see in a normal patient, it was all balanced with eye in a normal, but here there is left-sided sudden loss of vestibular input. So patient starts developing nystagmus towards right side. The side of nystagmus is determined by the fast component of the movement of eye. So any abnormality on affected side will cause nystagmus on opposite side. This is an acute feature when the patient develops vertigo, spinning sensation, rotatory movements associated with vegetative symptoms like nausea, vomiting, perspiration, sometimes even diarrhea. But within a very short duration of 1 to 2 days, the central nervous system comes into action and it causes compensation. This is mainly done by cerebellum, and this is called cerebellar clamping. So once the cerebellar clamping happens, the nystagmus stops, patients develop a new equilibrium. But this is what happens in certain diseases where there is complete loss of one side of vestibular system and it does not come back. But most of the peripheral vestibular system, the disease usually recovers and the vestibular system comes back partially. So when it comes back, then again patient will have little vertigo, because any asymmetry till the central nervous system compensate will cause vertigo. Once the central nervous system compensate for the loss, then there will be no vertigo. So this phenomenon, this physiology is very important to understand the cause of vertigo as well as the treatment of vertigo. So once it comes back partially, again there will be cerebellar clamping and central compensation. So this central compensation is very strong, and most of the peripheral vertigo will be treated by itself by central compensation. But this is why the vertigo has remained neglected or not treated, because this mechanism takes quite a long duration to act, and so many diseases are recurrent disease. So by the time the central compensation has happened, there will be another episode of vertigo. So unless we treat the cause, this part of central compensation will keep on changing and patient will keep on having recurrent vertigo. So now we'll go to how to differentiate between peripheral and central vertigo. So what is peripheral vertigo? Is all vertigo caused by vestibular system, that is labyrinth and vestibular nerve. And central vertigo is all vertigo caused by vestibular nucleus and further connections like cerebellum, brainstem, and cerebrum. So 50% of overall all the dizziness is because of peripheral vertigo, 10% is central vertigo, 15% is pre-syncope or cardiologic cause of positional or postural blackouts. But it is always blackout and not rotatory vertigo, pre-syncope. 15% of them are caused due to psychogenic cause, and 10% have multiple of these causes. It is not only one cause, but multiple causes. So one of the most common example of multiple causes is presbyastasis. Like we have presbyopia, presbyacusis, like that. With aging, our vestibular system becomes little weak. There is peripheral neuropathy, there is visual impairment, there is proprioceptive impairment. So with age, there are multiple causes, and this cause goes into multiple causes like presbyastasis. Now coming to common causes of peripheral vertigo, and just enumerating here the central causes also. So today my talk will focus mainly on this peripheral causes. The most common of the peripheral vertigo is Bppv, or benign paroxysmal positional vertigo. 80% of peripheral vertigo is caused by Bppv. Then the second and third most common cause of peripheral vertigo is vestibular neuritis and Meniere's disease. And then there are other unusual, not so rare, but unusual causes of peripheral vertigo is labyrinthitis, perilymphatic fistula, TM joint syndrome, and certain drugs, mainly ototoxic drugs, which can cause damage to vestibular system and hair cells. And central cause, I will just enumerate so that we know what we are comparing to. So central cause, the most common cause is migraine, vestibular migraine. And then the other causes are vertebrobasilar insufficiency, cerebellar infarct or hemorrhage. And then there is infarct of brainstem called as ICA syndrome and PICA syndrome. And demyelination, mainly multiple sclerosis, and very rarely vitamin B12 deficiency. And there are certain drugs which cause central vertigo, like anticonvulsant, carbamazepine mainly, and alcohol. And certain tumors, benign or neoplastic, of cerebellopontine angle and brainstem, which can cause central vertigo. So, how to differentiate between peripheral and central vertigo? If you see less than 50 years of age, 80% of vertigo are peripheral vertigo. Peripheral vertigo are always much more intense. They are exacerbated by movement because they are much more intense because it is the sense organ. So if it gets disturbed, it will show immediately that there is disturbance. If it is a central disorder, usually patient has some type. If it is a slow developing central disorder, they have some time to compensate. While in peripheral vertigo, patient don't have time to compensate. So they have severe vertigo. More severe the vertigo, more chances of it being peripheral. And it has vegetative symptoms like nausea, vomiting, perspiration, and diarrhea, which is usually very uncommon in central vertigo. So if any patient have severe vertigo with nausea, vomiting, most probably there are high chances it is a peripheral vertigo. Then if we can see nystagmus, so in peripheral vertigo, the nystagmus is usually unilateral and either horizontal or rotatory, but never vertical nystagmus. In central, it can be any picture. So just seeing on nystagmus, you cannot say whether it is peripheral or central, but if you associate it with history, what is the history, what are the other comorbid conditions, and after examination, in more than 90% of cases, you can reach to diagnosis only by taking history and proper examination. And only 10% of patient will require investigation to know the diagnosis. But sometimes if you are suspecting very bad diagnosis like cerebellar infarct, you may over investigate, but it is mostly by history and examination that you can pinpoint to the diagnosis. And what is uncommon is even peripheral vertigo, the auditory symptoms like hearing symptoms are very uncommon. So balancing system is a distinct system from hearing system, and both have different peripheral sense organs, both have different nerves, cochlear nerve and vestibular nerve. So most of the peripheral vertigo affects only the vestibular system and vestibular nerve. But there are certain peripheral vertigo like labyrinthitis or Meniere's disease where both hearing and balance are affected. So if the patient does not have any hearing symptoms, it is not a peripheral vertigo. That is a wrong concept. Most of the peripheral vertigo will not have any hearing symptoms. Similarly, if the patient has a CNS symptoms like dysarthria, diplopia, then we have to always consider central vertigo, and we have to investigate in the line of central vertigo. So now, how to diagnose based on history and clinical examination? So if any patient comes to us, first we have to take the history, and based on certain points like how acute, is it acute or chronic, how severe it is, whether the duration is for few seconds, few minutes, few hours, or it is continuous for days, and then whether any ear symptoms, hearing symptoms are there, whether any central symptoms are there. These are all the symptoms wise, history wise. Through history only, mostly you can have a very you can localize to only 1 or 2 diagnoses based on history alone. And then with examination, you can rule out other diseases. So what is the importance of history? Like, we have to ask first, actually, what does he mean by dizziness? Because patient means many things with chakkar. Sometimes they say, ke, I cannot walk properly. I am feeling unstable. I am seeing double things or disturbance of vision. But if the patient says they have a rotatory vertigo, true rotatory vertigo, then it rules out all other causes like cardiac and functional causes. But then also we have to take proper history. Then second is how much duration the vertigo lasts. Usually if it lasts for only few seconds, like it comes for a few seconds and goes away, then most probably it is BPPV, like, and it is associated with change of position. Like if they change the position of head, or if they try to sleep and get up from the sleeping position and they have a few seconds of severe vertigo, it is BPPV. But if it is lasting for many minutes or up to hours, 3-4 hours, then the probable causes is, in case of peripheral vertigo, the probable cause is Meniere's disease. In case of central vertigo, it is migraine or vertebrobasilar insufficiency. Similarly, if the patient has a prolonged vertigo, like more lasting for more than 1-2 days, 3 days, then it is, in peripheral vertigo, the most common cause is vestibular neuritis. And in central vertigo, the most common cause is posterior circulation stroke. That is either brainstem stroke or cerebellar stroke or hemorrhage. So if the duration is very short, it is much more likely to be a peripheral vertigo. If the duration is very long, then you have to seriously rule out posterior circulation stroke. Second is, as we said, severity is more severe in peripheral cause. And there are distinct causes in both peripheral and central vertigo where it is episodic. So it comes, it goes away, and the patient becomes completely normal in between. And then it comes back again. So such episodic vertigo, there are certain diagnoses like Meniere's disease or migraine, which are episodic. And the continuous vertigo, as we discussed previously, are those prolonged vertigo which are continuous. And then we have to ask for provoking factor. How does it increase? Whether it increases, it is continuously there, whether the patient moves or does not move, whether patient is in sitting position, sleeping. If it is a continuous vertigo, or it increases with positional changes, increases with stress, increases after viral infection, then we have certain differential diagnosis. So if it is spontaneous, the most common cause is vestibular neuritis or posterior circulation stroke. If it is positional, most common cause is BPPV. If it is induced by stress or physical activity, it may be migraine. So, and if it is followed by viral infection, upper respiratory infection, then it could be vestibular neuritis. So that is how we slowly take history and start coming to pinpoint one diagnosis. Then we can ask for other ear symptoms like hearing loss, tinnitus, ear fullness, pain, discharge, facial weakness. But as I told, it is present in less than 10% of patients of peripheral vertigo. And we have to ask for neurological symptoms, whether there is numbness, weakness, incoordination, difficulty in swallowing, slurring of speech, diplopia. So whenever you have these central symptoms, we have to investigate on the line of central vertigo. We also have to take medical history for migraine, hypertension, diabetes, smoking and PVD, head injury, ear surgery, and whether any past history of any psychiatric illness. This will rule out the causes of vertigo, and it will help us in diagnosing proper cause. In ENT examination, we usually, the ear examination is normal, tympanic membrane is normal, but in certain cases of labyrinthitis, there will be acute otitis media or cholesteatoma. We have to see for any herpetic vesicles in external canal to rule out herpes zoster induced vestibular neuritis. And hearing assessment. So the most common assessment now is to see the nystagmus. It is difficult to see nystagmus when you are not used to seeing the nystagmus. But when you make a patient wear this Frenzel glasses is a high diopter glasses. That is 20 diopter glass. And if the patient wears this 20 diopter glass, the visual compensation goes away and the nystagmus increases if it is a peripheral vertigo. If it is a central vertigo, the nystagmus will remain same because vision has no impact on central vertigo. But our eyes try to compensate for the movement of the nystagmus. And if you take out the role of eye by making patient wear a high diopter glasses, then the nystagmus increases. So this is one of the easy way to see nystagmus. The second, this is just for our way how to see what is the nystagmus. Nystagmus is this movement of eye. Here we can see the nystagmus towards left side or right side. This is left eye, so it is moving towards right. Again, if you can see again, just to see the fast component of eye is towards this side, left side. So that is how we see this is a horizontal vertigo, horizontal nystagmus towards right side. Now next is this is vertical nystagmus. This is the eye is moving in the vertical direction. If you see this movement in eye, it is always central vertigo, and you have to investigate. There are high chances of cerebellar infarct or hemorrhage. So we see nystagmus either through naked eye or by making patient wear high diopter glasses. Then we see the nystagmus by changing the movement of eye, that is gaze evoke nystagmus. The nystagmus usually increases when the patient sees on the affected side. Like if there is right side beating nystagmus, if you tell patient to look towards right, it will increase. And when you tell patient to look towards left, it will decrease. So this is very standard way of peripheral nystagmus. But central nystagmus, it will not increase or decrease based on movement of eye. It will remain same. It will remain same with high diopter glasses. It will remain same with movement of eye. That is what is classical of central nystagmus. And peripheral nystagmus will change depending on certain maneuvers. And there is classical positional nystagmus. This is how we diagnose Bppv. If you make patient sleep in a particular position, only then the nystagmus will be there. If the patient sits up from that position, there will be no nystagmus. So only in certain position, if the nystagmus is there, it is called Bppv. That is, there are different maneuvers, as I will discuss again later on. And then you can stimulate the labyrinth by cold and warm water, but this is now no longer done routinely in examination stage. Only in certain cases where we want to diagnose further, then we do this. But one very important clinical examination is this head thrust test, which is called Holmegi's head thrust test. This is to diagnose. See, if we remember in history, we have learned if the patient has continuous vertigo for 1 or 2 days, then we have to rule out between vestibular neuritis and posterior circulation stroke. So this is the one test which is highly sensitive and specific. If this test, the patient's eye movement is normal, then it is a central vertigo. I will just show you how it is. This is, so with this animation, we can see in a normal patient or in a patient with posterior circulation stroke, when you move the patient's head suddenly, I will show you the video also, then what happens? The eye will move in exactly opposite direction and patient will be able to focus on the same object, if even with fast movement. So this happens in normal patients or in patients with posterior circulation stroke. But if the patient is having vestibular neuritis, if the patient is having severe vertigo for 1 or 2 days, and if you do this test in this patient, the patient's eye will not be able to compensate immediately. So you see again, this is how vestibular neuritis patient, the patient head will move, the eyes will go along with the head, and after a few microseconds, it will compensate again and come back to normal. So this is very standard of vestibular neuritis. So this is a video again showing the same thing. See, if we are moving patients toward left, see, right, it is not, the eye is able to focus on the same object. But when we move on the left, the eye goes on the left and then come back to again center. It is very fast. So you have to train yourself to see. So if you see again now this, see here the eyes are moving exactly according to the head movement, and a patient is able to focus his vision on one object. Whereas here the eyes are going along with the head for certain time and then it compensates and come back to the object. So that is what is seen in this video. Once again, this alone single maneuver can diagnose whether it is vestibular neuritis or posterior circulation stroke. See, right side it is not moving, left side eyes are going there and then coming back. It is very short movement, but this means patient has left-sided vestibular neuritis. And then for neurological examination, we have to examine cranial nerves. We have to do cerebellar function examination like dysdiakinesia or finger nose test. And most common is postural test like Romberg's test and Utterberg's test. Romberg's test is we make patient stand with feet together and eyes closed, and we see for any unsteadiness or movement. So in all peripheral vertigo patient, in acute vertigo patient will not be able to stand like this and patient will be moving. And in certain acute vertigo, when there is immediate loss of vestibular function, patient will tend to fall on the affected side. Like if there is right vestibular neuritis, patient will tend to fall on the right side. Similarly, when we ask patient to walk in the same spot for 50 times, usually when normal patients, normal population, they are able to walk in the same with plus minus 30 degree variation only. But in patients with peripheral vertigo, they will move by more than 60 degree towards the affected side. So there is too much of information in short time, so I am sorry, but we can discuss during this. So history and examination usually will give us pinpoint to one or two diagnoses, and most probably in 90% of cases you will be able to pinpoint to one diagnosis, that this is the diagnosis in this patient. Majority of patients have acute vertigo, but if you don't diagnose during that acute vertigo, then they all go into non-specific dizziness and disequilibrium. And so it is easy to diagnose the patient during the acute stage, first 1 or 2 days. But if the patient comes to you after 10, 15, 20 days, or patient comes to you after taking Stametil for long duration, then it will be a compensated vertigo and it is very difficult to make the diagnosis. So this is the importance of patient. When the patient comes first time to any doctor, that is the golden opportunity to diagnose what is the vertigo. And most of the causes are benign and self-limited. That is why we don't bother about diagnosing the cause. But these patients, like simple Bppv patients, will with a simple maneuver of 5 minutes, they are cured of their vertigo. But if you don't do that maneuver, sometimes the patient will have vertigo for 3 to 6 months. Over the time, it will be self-limited and they will be treated. But 3 months of agony on the patient side, just because of not being able to diagnose Bppv and not able to do maneuver. And the patient takes so much of medicines for 3 months, which usually we can treat within 5 minutes. If you suspect serious cause, then we have to obviously investigate further. So what do we investigate? So there are 3 gold standard investigation: audiometry to rule out any hearing loss which we don't pick up. Video nystagmography is the way to see this nystagmus. It is a much more sensitive and specific way to see the nystagmus and eye movements in different movements. So this is required in 10% of cases of vertigo. 90% of patients we can manage without this. And then MRI with MR angiography when we are suspecting central cause and we want to rule out central cause of vertigo. But in my practice, because I get more of peripheral vertigo, more than 95 to 97% of patient MRI will be normal. So that is not our priority to do MRI. our priority is to take proper history, examine and treat 90% of our patients without any further investigation. So now we come to these three common peripheral vertigo causes. As I told, benign paroxysmal positional vertigo, as the name goes, it is benign, it is self-limited, it is paroxysmal, it comes in episodes, it becomes normal again comes in episode. And the third is positional, it is always positional. When you are not moving, it will not be there, it will be only there when you try to change your position. So the name itself says the diagnosis, it is Bppv, benign paroxysmal positional vertigo. It is severe vertigo because it is a peripheral vertigo, it will be severe. On the first day when patient is, like, we can diagnose most of these patients on telephone. If the patient says I am not able to get up from my bed, or I get severe vertigo when I try to roll over in my bed, then we know it is most probably Bppv. It is severe, it is associated with nausea, vomiting when it is happening for the first time. When it is happening for fourth, fifth time, the central system now knows that what is this input, and then patient will not have severe nausea, vomiting. But in the first or second episode, patient will have severe vertigo with nausea, vomiting, and it occurs only when they change head position. So patient will refuse to get up from sleeping position. They will say that I just don't want to get up from my bed because I am having severe vertigo. This patient again will not have any hearing loss or tinnitus because it is only vestibular system which is affected. The nystagmus is very classical. I will show you again how the nystagmus is. It is a rotatory nystagmus and it is fatigable. That is, if you do the test again and again, it will slowly becomes less and less severe. But we should remember one thing, all positional vertigos are not Bppv, but more than 95% of positional vertigo are Bppv. So what is Bppv? Again, the pathophysiology of Bppv is the surrounding bone. This entire vestibular system lies in the labyrinthine bone, which is the strongest and densest bone of our body. So if this bone becomes less dense due to osteoporosis or due to some injury, then certain bony particles dislodge from the bone and comes into the semicircular canal. This semicircular canal are filled with fluid, and these semicircular canals are open on one side, and on the other side it is closed by ampulla. So ampulla is the sensory organ of semicircular canal. So when these bony otoliths dislodge and touch the receptors, then the patient will have vertigo. If the patient does not move, this bony otoliths will not move and patient will not have any vertigo. And how to cure this Bppv? We have to take out these bony particles from semicircular canal and then put it into vestibule. If these otoliths come out of the semicircular canal, patient will be solved of the disease. What we do is we give medicine to numb this ampullary receptors. That is, either stugeron or stametil will decrease the impulses from the vestibular system, but it will not treat the cause. The particles are still there, and over the time these particles slowly may go out of the system, but it is possible to remove these otoliths immediately once we know how which canal of labyrinth is involved. So 90% of Bppv involves posterior semicircular canal. If you see this semicircular canal, the particles has to go against the gravity. So these particles will not come out immediately. So these are the commonest canal involved. The lateral canal is the second most common. In the superior canal, it is against gravity. So the particles will tend to fall by itself also. So superior semicircular canal Bppv are self-treating by itself. But posterior semicircular canal, we have to do maneuver and treat them. And second common is lateral semicircular canal in 8 to 13% of cases. 90% of Bppv is posterior semicircular canal, and 1%, less than 1% is superior semicircular canal. So there are maneuvers to diagnose whether it is posterior semicircular or lateral semicircular canal. So first we will see the maneuver which will diagnose posterior semicircular canal Bppv. It is a very simple maneuver. We can, if most of the times this patient will not get up from the bed, and sometimes we are called at home, or usually we give instruction to give Stametil tablet or injection, so that but if you give Stametil injection, then you cannot see this nystagmus. So if you are if you go to the patient's place and if you do this simple maneuver, we will know that it is Bppv and it is right or left posterior semicircular canal. So what we do, we make the patient sit, turn the head 45 degree. So if we turn it on the right side, we are checking the right posterior semicircular canal. If we turn on left side, we are checking the left posterior semicircular canal. And with that turn head, we make the patient sleep with the head hanging down. So I will show you again. This is, we are checking left side. So we are changing 45 degree head towards left, and then we make the patient sleep with head hanging down. If the patient develops severe nystagmus, then we know that it is left posterior semicircular canal Bppv. And similarly for horizontal or lateral canal, we make patient sleep straight. And then if we turn head towards right and patient has nystagmus, then it is right lateral canal nystagmus. And if we turn towards left and if the patient has nystagmus, it is left lateral canal Bppv. So these three maneuvers, these are easy maneuvers, can be done at any place, and we will know the diagnosis whether it is posterior or lateral semicircular canal Bppv. Sometimes there are certain difficult cases, but we don't need to at present confuse ourselves. So I will show you the video here how to do Dix-Holpike maneuver is for posterior semicircular canal. So we are checking for the right side.
Head is turned 45-degree angle to the right. Test with Dix-Holpike position to the right side. One looks for nystagmus at this point and may proceed into treatment or may have him sit back.
Now this is supine roll test or lateral canal test.
With the supine roll test, the patient is taken straight back on a flat surface. The head is turned quickly to one side.
This is for right lateral canal.
Gauges the intensity. The head is then turned straight back up.
And if you turn on left, it is for left lateral canal.
To the opposite side.
So what happens if you can diagnose, then at the same time you do maneuver also. So within 5 minutes you have made diagnosis and you have treated the patient. And on the same day of vertigo, patient is cured of his vertigo. But we should, if you give injections, if the nystagmus becomes very less, then it becomes little more difficult to diagnose, and then we take some time, or we would have to investigate further, like we have to do video nystagmography. But most of the patients, if they come to us within 2 to 3 days, if they have not taken any vestibular suppression in last 4 to 6 hours, we can elicit this nystagmus and we can cure this Bppv. The second treatment is patient is having severe vertigo, nausea, vomiting. We have to give symptomatic treatment. But if it is ideal that first we make diagnosis and then give symptomatic treatment. But if we give symptomatic treatment, patient will be relieved. But then to make diagnosis will become little difficult. And as we saw, all the Bppv most common cause is osteoporosis. So either vitamin D deficiency or calcium deficiency. So these patients will have recurrent vertigo. If we cure them now, after 1 or 2 years, they will have again Bppv because we have not cured the osteoporosis. So after treating Bppv, we have to treat osteoporosis. Otherwise, these patients will have recurrent Bppv. So patient can take calcium supplementation exercises to prevent recurrent episodes of Bppv. So now how to do the maneuver? Once we will see this video how the maneuver works.
Bppv can be treated by repositioning the displaced crystals with a simple procedure called Epley's maneuver. The maneuver takes about 10 to 20 minutes to perform, and it cures most of the cases. It consists of moving the head in a sequence of positions, which moves the displaced crystals into an area of the internal ear from where they cannot stimulate the balance nerve. Let us assume that the right ear is affected. The patient begins in the sitting position. Patient is then made to turn head in the direction of the affected ear and lie down with head hanging.
You can see the animation here, how the otoliths are moving inside.
Semicircular canal. The motion of the crystals produces a spinning sensation lasting for about 20 seconds. The patient is made to lie in this position till the dizzy sensation stops. Next, the patient's head is turned through the opposite side, causing the crystals to move and the vertigo recurs.
With each movement, patient will have vertigo, so we have to ask patient not to worry, and we will treat vertigo.
Carrying the head along so that the nose points downward. The crystals then move toward the front portion of the semicircular canal, producing vertigo again. The patient waits till she feels comfortable before getting up into the sitting position.
So this simple maneuver usually consists of these 6 positions,
Following
and
the procedure, the patient can go home. Patient should take the following precautions. For the next 2 nights, she should sleep at an angle of 45 degrees. And for the entire week following the procedure, patient should not sleep in a position in which the affected ear comes downward. Remember,
so that's for posterior semicircular canal. And there are other maneuvers sometimes for if the Epley's maneuver patient is not treating. I will not go into detail, but it is basically it is easy to remember that Dix-Holpike maneuver or simple 45-degree turn head and make patient sleep is the easiest way to diagnose posterior canal. And then to make these turns is Epley's maneuver, it is called, is the maneuver to treat the patient. Similarly, for lateral canal, once we diagnose that it is a lateral canal Bppv, there is a maneuver called barbecue roll. Like we roll the patient 360 degree like a barbecue roll, and I will show you the video.
Head is turned 40.
Again, this is for posterior canal.
Positioning to the right side. One looks for nystagmus at this point and may proceed into treatment or may have him sit back. With the supine roll test, the patient is taken straight back on a flat surface. The head is turned quickly to one side. One looks for nystagmus, gauges the intensity. The head is then turned straight back up. And the same thing is done to the opposite side. The examiner can then compare the intensity of nystagmus to determine the affected side.
Now this is barbecue roll maneuver for right lateral canal.
Benign positional vertigo is performed by having the head turned in a sequence of maneuvers 90 degrees to the unaffected side. In this case, the right side is affected, so the head is turned toward the left. That position is held for 10 to 30 seconds, depending on the duration of nystagmus. The head is then turned to the face down position.
We are rolling the patient
Held
360
again in that
degree
position for 15 to 20 seconds. Another turn. Now back toward the right side. And then from here, the patient turns to the straight supine face up position and then sits up simultaneously.
So during this maneuver, usually patient have quite severe nystagmus and vertigo. They may have some nausea sensation. So we have to just convince patient that it is just a temporary thing and it will go away, don't worry. And we have to complete the maneuver. The second diagnosis, so as we see in Bppv, most probably there is no role of medicines. Acute vertigo, sometimes patient may require medicine for 2 to 3 days, but not more than 3 days. So I am not going into the medical treatment. Medical treatment is same for all vertigo. At the end, we will talk about it. The second diagnosis, which is peripheral vertigo, most common is vestibular neuritis. What is the pathophysiology? Is the vestibular nerve is affected by herpes simplex virus. Like in Bell's palsy, facial nerve is affected by herpes. In sudden ascent loss, the cochlear nerve is affected by herpes simplex virus. So in vestibular neuritis, the vestibular nerve is affected by herpes simplex virus. This is a seasonal virus. Usually it happens during overlap of seasons, like when the winter is going and summer is coming, like this season, February, March, or when the winter is starting during November. So it, because at this time the virus reactivates, and at a time in a population you will see 3 to 4 patients out of 1 lakh population will get this vestibular neuritis. And these patients will come when you have patients of Bell's palsy, when you have patient of sudden ascent loss. So all 3 diagnoses are the virus is same, but they are affecting different nerves. So at a time in a year, there will be few periods where there will be many cases of vestibular neuritis, and there will be time when there will be almost no case of vestibular neuritis, because it is a seasonal virus. This patient will have sudden affection of one vestibular nerve, either complete common vestibular nerve or superior or inferior vestibular nerve. So what happens, like in Bell's palsy, there is complete paralysis of facial muscles. Here there will be complete paralysis of the vestibular system on one side. So if you remember the animation before, these patients will develop severe vertigo, and then over the time, next 3, 4, 5 days, patient will have reducing vertigo because of central compensation. So what do we do during for these patients? First, we have to diagnose that it is vestibular neuritis and it is not a posterior circulation stroke. There are easy ways to diagnose, like horizontal nystagmus, Romberg and Attenberger test. Patient will fall towards the affected side. The head thrust test, which we discussed, will be positive. That is a very classical test for vestibular neuritis. And if you put cold or hot water on the affected side, patient will not have any vertigo. Normal people, normal population, they will have vertigo. So in these patients, you require to give medicines for first 3 to 7 days. We have to settle down the acute vertigo symptoms. We have to give oral steroids, because this viral infection, we have to reduce the damage to viral nerve. But if the patient comes within 1 to 2 days, if the patient comes after 7 days, there is no role of oral steroids. If the patient comes in an acute stage, you can give oral steroid and antiviral. And these 2 drugs have a drastic effect on vestibular neuritis. Almost the patient within 24 to 48 hours will have 90% reduction in vertigo. So the more important drugs are oral steroids and antivirals, and vestibular suppression like Vertins, Tugerons, Tramadol is just for symptomatic treatment, and antiemetics, they like to prevent vomiting. But you will require vestibular symptom suppressions only for 3 to 5 days. Then we have to start vestibular rehabilitation exercise. What is this exercise? We have to retrain our central nervous system to work with a damaged vestibule. And central compensation is very strong, and it will help us to regain our vestibular balance. But it may take various duration based on the age of the patient and the physical activity of patients, from 6 weeks to 6 months. If the patient is elderly, above 70, 75 years, it may take long duration, about 1-2 years also, to compensate completely. But the treatment is rehabilitation exercise and not medicine. And third disease, this is the last disease of peripheral vertigo, which will be is Meniere's disease. In this, there is increased pressure of the fluid in the vestibular system. That is, the labyrinthine fluid pressure increases because endolymphatic sac, which is supposed to drain the fluid, is not working properly, not absorbing more fluid, or the fluid production is more. So whenever the inner ear pressure increases, it will cause 2 things. It will damage the hearing. So patient will have hearing loss, tinnitus, and fullness of the ear, and it will cause vertigo because the vestibular system will be stimulated. And the patient will have sense of pressure like ear fullness because of the increased pressure in the inner ear fluid. So this is the classical triad. Initially, the patient will have one episode and then he will be free of the vertigo for next 2-3 years. But over the time, this is a chronic inflammatory disease. So it will keep on coming back initially after 1 to 2 years. But as the disease progresses, the patient will have recurrent episodes of vertigo every month or every week. And when it becomes severe enough, the patient starts getting vertigo every second or third day. This vertigo will last for 30 minutes to 2 hours. It will be very severe. Patient will have nausea, vomiting, perspiration. Sometimes patients will have fall episodes. Patient will fall down. He will be conscious. He knows he's falling down, but he cannot control. So this is the only disease which is chronic disease. First and second disease, Bppv and vestibular neuritis, are acute disease, and they are solved at the same time. But this disease requires time to evolve. So initially we have to manage them symptomatically. But over the time, once we know that it is a Meniere's disease, it is causing hearing loss, it is causing tinnitus, it is causing ear fullness, then there are two permanent solutions for these patients of Meniere's disease. One solution is to put gentamicin injection in the middle ear. Gentamicin will damage the dark hair cells which produce the fluid. But the disadvantage of gentamicin is it can also damage the cochlear hair cells and cause some hearing loss. If you give gentamicin weekly once for 4 times, 90% of the Meniere's disease patients will be treated permanently. What we are doing is, what is a recurrent disease, we are making it a one type permanent vestibular loss so that central compensation can happen. But so many times the dark hair cells become resistant to gentamicin and they start developing fluid again and Meniere's disease recur. So if the patient wants a permanent solution, then the last and the best treatment option is vestibular nerve section surgery, where we cut the vestibular nerve so that the whole vestibular system, the input becomes zero to the cerebellum and brainstem. And the cerebellum and brainstem are very fast to compensate for complete vestibular loss. So what we do is we make Meniere's disease vestibular neuritis. We cut the nerve so that the fluctuating signal become a single signal. Like vestibular neuritis is the same form of Meniere's disease, but it is one time episode. This keeps on happening again and again. So if you cut the vestibular nerve, the hearing loss stops, the vertigo stops, and the patient becomes like near normal like he was before. Normally the Meniere's disease lasts for 10 to 15 years. So, and it happens in middle age. So what happens? A person loses 10 important years of his life because of recurrent vertigo. They stop driving, they stop going alone outside, they are afraid to stay alone in the home. So it is a very incapacitating disease. We feel that it is a very small disease, but the patient who suffers have a very incapacitating quality of life. And there is a easy way out for these patients. And the last labyrinthitis happens. It's so many times it is not labyrinthitis, but vestibular neuritis and sudden SN loss happening together. That is when both vestibular nerve and cochlear nerve are affected by herpes simplex, or more commonly herpes zoster virus. They develop both severe vertigo as well as acute hearing loss. And here again the treatment is same, antivirals and steroids, and then vestibular compensation. But sometimes this labyrinthitis happens because of bacterial infection from acute otitis media or cholesteatoma, and in that case we have to treat the primary pathology. The last few words on cervical vertigo. All these Bppv patients were initially treated as cervical vertigo because when the patient was moving, patient was having vertigo, and if you put a cervical collar and stop making a movement, patient will be solved of the Bppv. So, and patient himself will make the cervical muscles very stiff so that he or she does not move. But this patient had no cervical spondylosis. If you remove the collar and make them sleep again, they will have vertigo. So it was actually not the cervical vertigo, but it was Bppv which we were treating as cervical vertigo. And real cervical vertigo, where there is deep upper cervical neck muscle inflexion, is very, very rare. And acoustic neuroma again is the last cause of vertigo. It is vestibular nerve schwannoma actually, but this tumor happens so slowly that most of these patients will not have any episode of vertigo. So last few slides, management, as we all know, medical management for acute treatment of vertigo, but we should remember that most of the vertigo, we have to diagnose the cause. This is a symptom and this is not a disease. Almost 90% of my patients come with the diagnosis that I have vertigo. They don't tell us history, they don't tell anything, they have only one thing, or they are afraid, do I have vertigo? But none of our patients come with the symptoms like I have fever, and they want diagnosis that what is the cause of my fever, whether it is dengue, malaria, typhoid, tuberculosis. But here they and most of us also feel that all vertigo are same. Just we have to give this 4 medicine and patient will be solved of the disease, but that is not the case. There are different diagnoses for vertigo. We have to diagnose the disease, not the symptom, and cure the disease. And vestibular exercises, as we see, has a very important role in vertigo management. For Bppv, the maneuvers are one type of exercises. For vestibular neuritis, for compensation, for Meniere's disease, for all the diseases, vestibular exercise has a very important role. And lastly, the summary take-home points is we should understand what the patient means by dizzy, because there are 4 types of dizziness, whether it is rotatory vertigo, whether it is unsteadiness, whether it is syncope, or whether it is a floating sensation. Then we have to differentiate between central and peripheral. And we have to remember 90 to 95% of patients will not require MRI angiography. Peripheral vertigo is 5 times more common than central vertigo. And 80% of true vertigo, rotatory vertigo below 50 years will be peripheral origin. So we have to treat the underlying disease and we have not to treat the symptom of vertigo. And Bppv, that again the short, it is history and maneuvers. Meniere's disease, again we have to initially try diuretics, medicines and low salt diet, but if it does not work, then there is treatment of either intratympanic gentamicin or neurectomy. And in vestibular neuritis, we have to start steroids and antiviral early, and we have to start vestibular rehabilitation exercise early. And always remember, there is central vertigo are less severe, but sometimes more dangerous. So we have to keep in mind and diagnose and rule out central causes. Thank you.
Thank you, Dr. Bhavin. That was so good. No, a rather seemingly complex subject, you have tried to make it very simple and very crisp and rational messages on the management part, that we need not over investigate, and treatment is not only related to medicines. There is much more to it than just giving medicines. So thank you so much for this elaborate talk. There is one question in the chat box, and that is from Dr. Janardhan. It's regarding what is the commonest cause of vertigo in pediatric group?
Pediatric patients, usually I have not seen Bppv commonly unless patient has some head injury or trauma. So the most common cause of vertigo in pediatric patient is pediatric migraine. That is what is my experience, and overall worldwide also migraine causing vertigo is more common in pediatric patients than any other diagnosis. And if you treat migraine, the vertigo goes away.
Right. So we have a little bit overshot the time today.
Yes, sorry sir.
No problem, because you were so involved in giving all the necessary information, so we understand. But there are no questions anyway in the chat box now. So we end the session, and thank you very much, Dr. Bhavin Parikh, for giving your time. I know you have a surgery just now after this talk, and it was so good on your part to have spared time for us. So thank you so much, and we meet again next Saturday. Thank you.